What's up, Ninja Nerds? In this video today, we are going to be talking about cardiomyopathies. There is a lot to cover, so let's go ahead and get right into it. All right, so when we talk about cardiomyopathies, there's three different types of cardiomyopathies. There is dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. We should have a good understanding of the basic definition and the particular etiologies or causes for these disorders. So dilated cardiomyopathy is a dysfunction of the myocardium of the heart due to the dilation of the chambers of the heart, the atrial chambers, the ventricular chambers, right? Now, the question is what leads to this ventricular and atrial dilation of the actual chambers and thinning of the walls? That's a great question. And at first, before we actually talk about these little extra causes, I want you to remember a mnemonic to remember the most important causes. And you know what that mnemonic is? A bunch of stuff can cause cardiac dilation, my friends. So a bunch of stuff can cause cardiac dilation. A for alcohol abuse. B for beriberi, wet beriberi. You know that's a thiamine deficiency. Can for Coxsackie B virus. The cause for chronic cocaine use. The cardiac for Chagas disease, and dilation, doxorubicin toxicity, which is a chemotherapeutic agent. There's another one called daunorubicin. But these are the most important ones. If you got a little extra brain space, don't forget three other particular etiologies. You know when a patient is actually pregnant, particularly third trimester up to about at least less than 6 months postpartum, they have to meet a high demand. They got to get enough blood to flow to the pregnant mother and the baby. That puts a lot of stress on that woman's heart, and it can cause dilation over time. This is called peripartum cardiomyopathy. You know, unfortunately, if someone loses a very significant loved one, or they have a massive brain bleed, or they have a very severe type of septic infection, their sympathetic nervous system goes on haywire, and they have this massive catecholamine surge where it puts so much stress on the heart and it weakens it over time. You know what this is called? It's called Takotsubo or stress cardiomyopathy. So Takotsubo cardiomyopathy. High yield stuff you cannot forget for this one is that in Takotsubo cardiomyopathy, when they present, they may have signs of chest pain and shortness of breath, but when you go ahead and you do their EKG, they have ST segment elevation. Their troponins could be positive, but here's the key thing. You send them to get a CT of the coronary vessels, or you send them to get a cath to look at the vessels. They're clean. There's no types of obstruction. And when you look at an echo, they got this big apical ballooning of their ventricular chambers. That's Takotsubo. The last one that I want you to remember is tachycardic cardiomyopathy. You know when someone has lots of PVCs or they have atrial fibrillation in there in these very high rates and it's very sustained, that puts a lot of stress on the heart over time that reduces its diastolic filling process, and this can lead to dilation of the ventricular chambers and dilated cardiomyopathy. My friends, that's dilated. Let's move on to hypertrophic. Hypertrophic cardiomyopathy is a dysfunction of the actual myocardium of the heart, particularly the ventricular myocardium. And it's due to an asymmetric hypertrophy of the interventricular septum. So you see this septum right there? Look at that big beast right there, just pumping out there. That is the actual problem with this disorder. Now, what causes this asymmetric ventricular hypertrophy? That's a great question. It's usually genetic causes, and there's two types of genetics that I want you to remember. The more important one is an autosomal dominant condition. It's usually familial, meaning that it's passed on, it's inherited from a mother or father. And in this situation, the particular mutation is in a very specific protein that's incorporated into our sarcomeres, the structural units of our cells, muscle cells. And this protein, guess what? Got a little way to remember it, is in the heavy chain of myosin protein. What does that look like? Hypertrophic cardiomyopathy helps you to remember it. Now, that's one of the causes. The second genetic cause that I want you to remember, which could potentially come up, is a patient who has some type of neurological dysfunction, ataxia, weakness, and they have diabetes on top of hypertrophic cardiomyopathy. This is a condition called Friedreich's ataxia. It is not autosomal dominant. It is autosomal recessive with a trinucleotide repeat process. Okay, that discusses our hypertrophic cardiomyopathy. Let's go down into restrictive cardiomyopathy. All right, the last one is restrictive cardiomyopathy. This is the dysfunction of the myocardium due to fibrosis and infiltration of the cardiac tissue and interstitial spaces. And this causes a restrictive diastolic filling process. The ventricles don't want to fill very much. And so because of that, we have to think about particular things that can cause this fibrosis and infiltration. What is this? Remember rash. Rash for radiation fibrosis. You know, if someone has like some type of cancer within their mediastinum and they're getting radiation therapy, that can affect the heart and cause fibrosis. Or a big one, amyloidosis. Amyloidosis can cause misfolding of proteins and deposits into the cardiac tissue. You know what another one is? Sarcoidosis. Non-caseating granulomas get deposited into the cardiac tissue. And last but not least is hemochromatosis, which is iron deposition within the cardiac tissue. Two things I want you to remember here is that sarcoidosis and hemochromatosis, which again, non-caseating granuloma deposition, iron deposition subsequently, these not only occur in restrictive cardiomyopathy, but they can also occur in dilated cardiomyopathy. So don't forget that. Last but not least, before we go into the pathology, please don't forget this. Dilated cardiomyopathy, believe it or not, we talked about all these different causes. The most common cause of dilated cardiomyopathy, even though we mentioned all of them, is actually idiopathic. We don't really know why it happens. You know what else is interesting? Restrictive cardiomyopathy, we mentioned a bunch of causes, but you know what the most common causes of restrictive cardiomyopathy? It is idiopathic. So we talked about a bunch of causes, but please don't forget that dilated and restrictive are technically, their most common cause is idiopathic. Now that we've hit that, let's talk about pathology. All right, let's talk about the pathology of these conditions. Now, dilated cardiomyopathy, we know it's a dilation of the actual chambers of the heart. Let's focus a little bit on the ventricles because those are the primary portions I want to talk about. So whenever somebody has a dilated cardiomyopathy, here's their normal ventricular myocardium. You see how it's like naturally have a good lumen, not too thick of a ventricular myocardium? When you look at the actual like cellular component here, the protein structure that makes it up is called your sarcomeres. These are the structural and functional units. Whenever these contract, that's what actually produces the shortening and contractioning of the myocardium. If we take someone who has dilated cardiomyopathy, oh my gosh, look at the size of those ventricular lumens. They're huge, they're gargantuous. And then the ventricular walls are super, super thin. What causes them to go from this to dilate so much? This is called eccentric hypertrophy. What does that mean? We take these sarcomeres, and I'm going to add sarcomeres in a linear fashion, in a series type of fashion. When I add these sarcomeres in series, that causes the ventricular chambers to get bigger in diameter and thins out the ventricular walls. Think about eccentric hypertrophy. We're lengthening something. So you're increasing the size of the muscle, but you're doing it in a way that it's lengthening. And when you lengthen it, you cause the thinning and the dilation of the ventricular chambers. That should make sense. Hypertrophic cardiomyopathy, again, same thing. Here's your ventricular myocardium here. Nice good sized lumen, not too thick around the edges. That's their normal sarcomere that are making up those muscle cells. In hypertrophic cardiomyopathy, what's their problem? Oh my gosh, look at this interventricular septum. It's thick as ever. And because of that excessive thickness, and there's even some more thickening of the left free wall, and the lumen is super, super tiny. What happens here? The sarcomeres, we add them on top of one another in a parallel type of fashion. And when you do that, you increase the size of the actual muscle cells, but you do it in a way that the entire myocardium becomes thicker in a concentric fashion. However, in this type of concentric hypertrophy, it tends to favor one side of the left ventricle, the interventricular septum, so it tends to be asymmetric in this fashion. Please don't forget that. All right, let's talk about restrictive cardiomyopathy. All right, the last one, restrictive cardiomyopathy. Take a look here. Normal ventricular myocardium. When you take a look at the cells that are actually making up that myocardium, these are your beautiful cardiac cells. Now, what happens is you have these normal interstitial spaces between the cardiac cells. And you see how the cardiac cells look nice and healthy? In a patient with restrictive cardiomyopathy, imagine interspersed in these areas of the ventricular myocardium, I have all of this fibrosis, lots of fibrous tissue being deposited here, lots of infiltrative molecules being deposited into this area here, like iron and non-caseating granulomas and proteins. That starts to cause destruction of the cardiac tissue. There may be some also fibrosis and infiltration of the cardiac tissue itself. When that happens, it makes the ventricles just not want to stretch as much. They're very, very just not happy about being compliant or distensible, and that causes this pathological process. Now that we've covered the basic pathology at the cellular level, let's see how dilation of the actual chambers, how asymmetric thickening, and how this fibrosis leads to the pathophysiology and classic clinical features in these cardiomyopathies. All right, my friends, let's talk about the pathophysiology of these cardiomyopathies. So first, we'll talk about dilated cardiomyopathy. So we know that the primary issue is that there is a dilation of the ventricular chambers and the atrial chambers, but let's focus on the ventricular chambers first. When there's the dilation and you thin out those walls, you know what that does? The ventricular myocardium, it's really thin, it doesn't get a good contraction. And so the contractility of these dilated ventricles is very, very poor, as represented here by that part of the algorithm. So there's a reduction in contractility in this disease because of why? The very thin walls and the very large dilated ventricular chambers. Because whenever the ventricles are just too dilated, the preload's way, way too high. And usually when the preload's way too high, it stretches those sarcomeres beyond their optimal length. So it doesn't obey Frank Starling's law of the heart anymore. And so because of that, their contractility drops, right? And then also they're just weak because they're really thin. And that also reduces the contractility. So when you reduce contractility, what does that affect? Your stroke volume, right? And so if you have a reduction in contractility, you lead to a reduction in stroke volume. If your stroke volume drops, you lead to a reduction in cardiac output. Right? And if there's a reduction in cardiac output, then your actual perfusion to the tissues is going to be reduced. Your heart is failing at being able to pump blood out of the heart during systole. What is that called? That's called systolic heart failure or systolic dysfunction. And if your heart is starting to fail to pump blood out of the left ventricle during systole, that's called a systolic left-sided heart failure. If it's not pumping blood out of the right ventricle during systole, that is called a systolic heart failure on the right side. So what could be particular manifestations in these patients? Because they can have biventricular systolic heart failure. I'm so glad you asked. If they have right-sided heart failure, think about this. This right ventricle isn't contracting well. It's not pushing blood outwards into the pulmonary trunk. Because of that, it's going to back downwards through the inferior vena cava and back upwards through the superior vena cava. If it goes up through the superior vena cava, you're going to get jugular venous distension. If it goes downwards into the actual inferior vena cava, it leads to hepatomegaly, swelling of the liver, maybe even ascites, and it goes down into those lower extremities and plumps those up like the Michelin Man, causing pedal edema. Now, if the left side is failing, my left ventricle is not pumping blood out through the aorta. Instead, if it can't pump that blood out, it starts going where? Backing up into the atria, and then into the pulmonary vessels, and then into the lungs. And then fluid starts leaking out of those capillaries into the interstitial spaces around the lungs, causing pulmonary edema. When someone has pulmonary edema, fluid within the lungs, it makes it difficult to breathe, but there's particular positions and times when the breathing may be worse. When someone's laying flat, orthopnea, they're laying flat and the breathing becomes more difficult. That's called orthopnea. When someone's having difficulty breathing and maybe they're not laying flat, they're maybe standing still, they're sitting down, that's just regular dyspnea. And that can be at rest or it can be with exertion. But last case scenario, which is a very obvious factor here, is when they're laying down flat and during sleep, they develop a significant acute difficulty with breathing. That's called paroxysmal nocturnal dyspnea. These could be features seen with dilated cardiomyopathy because of a systolic heart failure. Don't forget that. Okay, hypertrophic cardiomyopathy. What's the pathophysiology here? This one's really interesting, a little bit more of a complicated one. So we said that there's a very thick left ventricle, right? But where is the thickness really occurring? We got to be specific, right? It's asymmetric. It's right there in the interventricular septum. Because it's really thick, it narrows the lumen of the ventricular cavity. Do you think a lot of volume can get into that ventricular cavity? No. So there's a reduction in the diastolic filling process. We call this a decrease in compliance, right? So whenever you have these ventricles being really thick and they're very large, when you want blood to come into them, you want them to stretch. In this disease, they're not very distensible. So because of that, their compliance is a little reduced. So we have an increase in thickness, a decrease in their compliance, their stretchability. Not much blood is coming from the atria down into the ventricles now. Their diastolic filling process reduces. If I have less blood coming into the heart during diastole, that's called my end diastolic volume. If that's low, that drops my preload. If you drop your preload, you drop your stroke volume. If you drop your stroke volume, you drop your cardiac output, and you can't put blood out of the heart. But the primary issue that led to this reduction in stroke volume was not during the systolic process. It was during the diastolic process. So this is a type of diastolic dysfunction which can lead to diastolic heart failure symptoms. Okay? We're going to come back to what those look like in a second though. The other thing in this patient is, you know what else? It's not over. Okay, you know when the interventricular septum contracts, look where it's near. You know when the left ventricle contracts, it wants to pump blood up here and into the aorta. That's the goal. When this interventricular septum contracts, everything shortens, right? And it squeezes down the blood. Guess what this son of a gun does? He bows inward. And now, do you think I can get blood through that narrow left ventricular outflow tract now? No. And so blood is just really squeezing through that little narrow left ventricular outflow tract. Something odd happens. When that runs through there, imagine a lot of blood running through a small space. This little valve leaflet of the mitral valve, that's called the anterior leaflet. It's like, imagine it just staying here and blood's rushing really fast behind it. All of a sudden, it starts getting sucked inward, in towards the interventricular septum. That is called the systolic anterior motion of the mitral valve. And you know why? It's because of that little sucking effect. It's called the Venturi effect. So then the mitral valve starts getting sucked towards the interventricular septum. And if that thing gets pulled inwards, it completely obstructs the left ventricular outflow tract. No blood gets out. If no blood can get out of the left ventricle, that significantly reduces the stroke volume, significantly reduces the cardiac output. Why is that a problem? Here's why. And this is the key thing, please do not forget this. If we have a reduction in cardiac output, and I don't get enough blood that's actually going to perfuse my coronary vessels, because you know the coronaries come off the aorta, right? If the coronaries aren't getting enough blood flow to supply the myocardium, this can lead to ischemia. And you know what ischemia of the heart can actually look like? Angina, chest pain. They can have shortness of breath, dyspnea on exertion, but the worst case scenario for these patients is that the ischemia is so severe because their left ventricle is in such high demand because they've been exercising, they've been working really hard, it can lead to complete sudden cardiac death via a very acute onset of VTAC or VFib. And that is what I want you to remember. You see the Grim Reaper coming for this young little boy, number 13? Unfortunately, it's not his day because he's exercising, he's working hard. His ventricular myocardium is working really hard. It has high demand. He has a dynamic obstruction. Not enough blood gets into his coronary vessels. Significant ischemia leads to VTAC, VFib. He passes out on the actual athletic football field. So that's one of the big types of clinical vignettes where you can see these types of cases. The last thing is, on the lower end of significance, is that if their cardiac output's significantly reduced and they don't perfuse the vessels that are going up to the brain, what can happen there? They can have a syncopal event. And they can also have a syncopal event because of the arrhythmias they can generate as well. But again, these are the big things that I need you to remember for a patient with hypertrophic cardiomyopathy. What about the pathophys for restrictive? All right, so restrictive cardiomyopathy, in this disease, what happens here? These ventricles, they're super rigid, man. They're very rigid. They just don't want to stretch, my friends. And because of that, they don't want to allow for blood to come into them. So what happens in these diseases, because of the fibrosis and infiltration, they're very, very stingy and they have a very significant reduction in their compliance. In other words, their distensibility. When blood is coming from the atria down into the ventricles, they just do not want to distend and allow for that blood to come in. They don't accept it lovingly. And so because of that, if you have less blood coming into the ventricles during the diastolic filling process, right, there's going to be a significant reduction in diastolic filling. What would happen there if there's a reduction in diastolic filling? You get less in diastolic volume, which leads to a reduction in preload. If you drop your preload, you drop your cardiac output. You drop your preload, you drop your stroke volume. If you drop your stroke volume, you drop your cardiac output. If you drop your cardiac output, you drop the perfusion to the particular organs of your body. And the heart is failing to be able to meet the demands of the body. But what part of the cardiac cycle is this heart failure occurring in? Diastole. So this is a type of diastolic dysfunction which can precipitate with a diastolic heart failure. So remember, for dilated, it's systolic. For hypertrophic, it's diastolic. And for restrictive, it's a diastolic type of heart failure. Now, if we have these issues where the heart failure precipitates, here's where you have a differentiating factor between restrictive and dilated. Dilated tends to have biventricular, where the left starts first and then causes the right. In restrictive cardiomyopathy, the right heart failure tends to predominate in symptomatology in comparison to the left-sided heart failure. Let's remind yourselves what the right heart failure symptoms were. If the right ventricle isn't getting an adequate amount of blood during the diastolic process, blood will back up into the superior vena cava, back up into the inferior vena cava. If it goes up to the superior vena cava, they can get what's called JVD. If it backs up into the liver, it can lead to hepatomegaly. If it backs up into your lower extremities, it puffs you up like the Michelin Man, causing pedal edema. That would be your right-sided heart failure. If the left side isn't accepting adequate amount of volume of blood, it's not going to be able to accept the blood has to back up somewhere. So it backs up from the atrium to the pulmonary vessels. Backs up from the pulmonary vessels into the interstitial spaces in the lungs, leads to pulmonary edema, which can lead to paroxysmal nocturnal dyspnea, orthopnea, or just dyspnea at rest or on exertion. And that will cover the big features and clinical features associated with the pathophysiology for these cardiomyopathies. Now let's talk about some very significant heart sounds that you may hear in these cardiomyopathies. All right, let's talk about the particular heart sounds that you can hear in a patient with these cardiomyopathies. So first one, dilated cardiomyopathy. Remember what I said, it's a systolic dysfunction. Now here's the interesting thing. Because those ventricular chambers are really big and dilated and the ventricular walls are really thin, they can accommodate a lot of volume of blood very quickly. So right when the atria's, the tricuspid valve or the mitral valve opens during the ventricular diastole, these ventricular chambers are gargantuous. They can accommodate a lot of blood very, very rapidly. And so once the diastolic process occurs and these valves open, blood starts flooding down into these ventricles. And what happens is during the rapid filling process, there's some turbulence of the blood flow into the ventricles. And it produces a very interesting heart sound that you can hear, particularly during the early phases of diastole. Right when the tricuspid and mitral valve opens, boom, blood flows in, turbulence occurs. This is called an S3 heart sound. And that is because of the systolic dysfunction that makes it super dilated and thin ventricular walls. Okay, what else? Now remember I told you in the beginning, the definition of dilated cardiomyopathy is all the chambers are dilated, not just the ventricles, but look at these big mama atria. Whenever the atria get larger and the ventricles get larger, guess what you do to the annulus? You know there's like a ring of fibrous tissue that holds these valves like down and kind of in place? And these patients who get these very, very large ventricles and atria, it stretches those annulus and pulls the leaflets farther away from one another. So when the ventricle contracts, those leaflets aren't close to one another to be able to coapt together and close. So guess what happens, my friends? When the ventricles contract, it pumps blood right back up into the atria during the systolic process. And this is called mitral and tricuspid regurgitation. These are holosystolic murmurs. And again, due to the stretching of that annulus. Okay, the next one that I want to talk about is hypertrophic. So we got dilated S3 and mitral regurg and tricuspid regurg. Boom. Hypertrophic cardiomyopathy. What happens with this one? So it's the opposite, right? We said this one was systolic. This one is diastolic. It's rigid. It does not want to accommodate blood flow into it during the diastolic process. So do you think it would give us a S3 heart sound? Probably not, because it's not going to rapidly fill blood into it. It's very, very rigid and it doesn't want blood to come into it. So you know what happens? The atria have to get kind of like a little jacked up. They got to get a little bit on steroids. And so they got to push this blood into the ventricles. But they got to push it against a high pressure because that lumen is very small, so the pressure in this ventricle is a lot higher. So in order for them to be able to push blood into the ventricles, they say, all right, time to do some weight training. And they get hypertrophic. They get thicker. And when they get hypertrophic, during the last phase of the diastolic process, they're like, get ready, ventricles. Oh, wow! And they contract super hard to push blood down to the ventricles. And when the atria really contract hard to push blood down into the ventricles, it produces a S4 heart sound called the atrial kick. And you can hear that in hypertrophic cardiomyopathy. So again, why is it? Due to the diastolic dysfunction, doesn't want to relax, doesn't want to accommodate blood. Atria got to get all steroided up, thicken, hypertrophy, and contract hard to push blood into them. Boom, roasted. Okay, what's the next one? You know, in a patient who has this hypertrophic cardiomyopathy, what do we say happens? When the interventricular septum contracts and bows inward, narrows the outflow tract. When it narrows the outflow tract, what did it do to the mitral valve leaflet again, the anterior valve? It's like, whoa! It's getting pulled back against the septum. What do we call that? Well, the Venturi effect, which created the systolic anterior movement of the mitral valve. When you yank the mitral valve that way, do you think it's going to be able to close together with the posterior valve leaflet and prevent blood from coming back into the atria? No. And so when the ventricles are contracting, some of the blood gets squirted right back into the left atrium. And this is called mitral regurgitation. So you can have mitral regurgitation, again, due to the Venturi effect, which yanks that anterior leaflet of the mitral valve towards the septum because of that Venturi effect. Last thing, and this is super high yield for HCM, when that actual dynamic obstruction occurs, you know, when the interventricular septum contracts and bows inwards and blocks that outflow tract, when it goes in and blocks the outflow tract, blood has a very narrow little area that it can squirt through. And when it does that, blood's gonna fly through that area as hard as it can, and that's gonna produce a very intense sounding type of murmur. But then after the blood squirts that narrow left ventricular outflow tract, what happens again? What does the anterior left leaflet of the mitral valve do? It's like, whoa, it gets pulled in. And then because of that, it kind of completely obstructs blood flow. And very little blood, if no blood, gets through. And then the heart sound actually kind of goes down. This type of systolic ejection murmur, because it's occurring during ventricular systole, can sound like it's going up because of the narrowing of the left ventricular outflow tract. And then when it gets very, very obstructed, the heart sound goes down in a decrescendo fashion. This is called a decrescendo systolic ejection murmur. Please don't forget that. And also don't forget that if you see this type of case, you can also have this in a patient with what's called aortic stenosis. But one of the things that may come up is when they're listening and they hear this systolic ejection murmur with a crescendo, decrescendo pattern along the left lower sternal border, or left sternal border, they go and listen to the carotids, they don't hear that sound in HCM. They would hear that in aortic stenosis. Don't forget that. Okay, another thing that you have to know, because they're gonna present this in your exam question, is if they say, okay, I want to accentuate the murmur. I want to make the murmur louder. In order to make that murmur louder, I got to make the obstruction worse. So again, if I want to make the murmur louder, I got to make the obstruction worse. So I got to make the volume of that cavity, that ventricular cavity, smaller. So what ways can I make the ventricular cavity smaller? I have less blood in it, okay? So what are the ways that I can have less blood in it? One is I drop my preload. I don't get enough blood coming to the ventricles during the diastolic process. How do I do that? I stand still. I'm not getting a lot of muscular milking activity going up to bring blood up. Or I Valsalva. I increase my intrathoracic pressure. That reduces the venous return. These are ways. And what it'll do is it'll make the amount of blood that's coming to the ventricles less, and that'll actually cause that obstruction to get worse and get closer to the actual left ventricular outflow tract, worsening the murmur. All right, so here's where it's a little counterintuitive, but follow with me. You want to reduce the afterload to increase the intensity of the murmur. Why? Okay. Stroke volume depends upon three things, right? Preload, contractility, afterload. Preload and contractility, they work in the same direction. So if preload goes up and contractility goes up, stroke volume goes up. If afterload goes up, then stroke volume goes down. If afterload goes down, then stroke volume goes up. Now, think about this. If afterload is going down, stroke volume will go up. If your stroke volume goes up, that means that you eject more blood out of the heart. That means less blood is sitting in the heart during diastole then. If there's less blood sitting in the heart during diastole, what's that going to do to the obstruction then again? It's going to worsen it. And that's going to worsen the intensity of the murmur. Now, what can we do to reduce afterload? We can actually give drugs like ACE inhibitors, ARBs, or we can give something called amyl nitrate, which is a little bit faster acting. And what it'll do is it'll vasodilate the vessels and drop the afterload, okay? The opposite scenario, if we want to lessen the intensity of the murmur, then I want to decrease the obstruction. I want to plump up those ventricles then. So I want to increase my preload. So if I squat down, that gives me a good milking activity, push blood up. Or if I'm laying flat and I have someone lift my leg up, that'll also create a kind of a gravity effect to suck blood down into the actual ventricles. If you do that, you get more blood into the ventricles. More blood into the ventricles will plump up those ventricles and relieve the obstruction. What else? Afterload, it's the exact opposite. If I increase my afterload, what do I do to my stroke volume? I drop my stroke volume. If I drop my stroke volume, that means that what happens? Less blood is being ejected out of the heart during systole. That means more blood is sitting in it during that diastolic process. That's going to relieve my obstruction a little bit, and that's going to decrease the intensity of my murmur. How do I do that? How do I actually increase my afterload? I use hand grips and I squeeze, and it increases my systemic vascular resistance, and that ups your afterload. That is what I really don't want you to forget for HCM. Let's hit it home with restrictive cardiomyopathy. All right, so let's talk about restrictive cardiomyopathy and the particular heart sounds that you may hear here. All right, so in this one, here's what's really interesting and somewhat counterintuitive. Remember I told you that, again, for dilated cardiomyopathy, it was a systolic dysfunction, and then for hypertrophic, it was a diastolic dysfunction, and restrictive, it's a diastolic dysfunction. So theoretically, in your head, you're probably thinking, okay, dilated is an S3, hypertrophic was an S4, so restrictive should be an S4. No, it's weird. It's actually an S3. Here's why. So During the during the early phase of diastole, the ventricles are actually at their most compliant point. They're not compliant in general, but in the early phases of diastole, that's the most likely time when they'll have a little bit of give and a little bit of likeliness to stretch a little bit. So what happens is right in the early phase of diastole, these atria have been holding on to a lot of blood and saying, okay, ventricles, get ready. And all that blood just floods down like rivers into the ventricles because the atria have just been holding on to tons of blood because the ventricles, they're not a big fan of taking and holding on to blood. So the blood has to stay somewhere and it stays in the atria. So right when those valves open, blood flows down very rapidly. And when blood flows down rapidly during the early phase of ventricular diastole and it produces a turbulent flow, what was that called again up there? An S3. And so that's why there is an S3 heart sound in this disease, even though it sounds counterintuitive, I know. Later in the disease, as the atria get more hypertrophic, they get a little bit more thick, they can develop an S4 heart sound or an atrial kick. But it's more prominently an S3 in the early diastole, and then usually in the refractory severe cases, maybe an S4. Okay, what else? Because I told you those atria have been holding on to blood, right? The ventricular pressure in the mid and later stages of diastole is terrible. It's really high. And so they don't accept any more blood. In the early phase, they'll accept blood. In the mid to late phases of ventricular diastole, they don't accept very much blood at all. So that blood's got to stay somewhere. It stays in the atria. Atria puff up like the Michelin Man. They get bigger, volume overloaded. They have to accommodate that higher volume. So what do? They make more space, so they dilate. And whenever the atria dilate by atrial enlargement, that kind of stretches those annulus of the tricuspid valve and the mitral valve, pulling the leaflets farther away from one another. When the ventricles contract, do you think blood can get up through these? Yes. And so this causes a mitral and tricuspid regurgitation. So please don't forget that. And you know what else is super important that helps us to differentiate, which we'll talk about later? There's a disease called constrictive pericarditis and restrictive cardiomyopathy. And oftentimes on your exams, you're going to have to be able to differentiate which one it is. And sometimes it's a little tough. One of the big signs here is that in restrictive cardiomyopathy, they have mitral and tricuspid regurgitation. In constrictive pericarditis, they do not. Don't forget that. Now, the last sign, which is a highlight of restrictive cardiomyopathy and compared to the other cardiomyopathy, is called the Kussmaul sign. Now, remember I told you, the ventricular cavities are very fibrotic. They're not a big fan of wanting to accept blood. In the early phase, they'll accept blood, but in the mid to later phases, they're not a big fan. When blood actually goes down from the atria into the ventricles during the diastolic process, it's good in the early phases, and then in the mid to late, it doesn't. So it just stays and sits here within the atria. The atria has to accommodate all that blood in mid to late ventricular diastole, but it's going to be too much. And so what happens is the blood starts backing up into the superior vena cava, into these little veins here at the top, these ones called your jugular veins, causing jugular venous distension. Now, what happens is when someone takes a deep breath, and normal patients, they take a deep breath, it does what to your intrathoracic pressure? It drops it. If your intrathoracic pressure drops, normally the blood within this venous system should get yanked down and sucked into the right atrium and into the right ventricle, right? But this right ventricle is not a very big fan of taking blood into it. So whenever you take a deep breath in, the intrathoracic pressure will drop, blood will start trying to come down, but guess what? Blood has been sitting in this atria and it doesn't really want to go into the ventricles. If it doesn't really want to empty into the ventricles, do you think it's going to dump down into the ventricles really well? No. So the jugular venous pressure or jugular venous distension stays the same even during inspiration. Normally, it should cause it to drop down. You should go here and have a quick tug down. But in these patients, the right ventricular pressure and right atrial pressure are just too high that even when you take a deep breath in and drop the intrathoracic pressure, the JVD does not drop. It stays around the same level. That is a very prominent sign that you see in restrictive cardiomyopathy, but you can also see it in constrictive pericarditis. Now that we talked about that, we got our heart sounds down, let's talk about the diagnostic differences between these cardiomyopathies and then compare and contrast restrictive cardiomyopathy versus constrictive pericarditis. All right, my friends, let's talk about the diagnosis and the differentiation between these different types of cardiomyopathies. So, first thing that you need to know with dilated hypertrophic and restrictive cardiomyopathy is the big types of tests that we're going to be utilizing here is your echo, your echocardiogram, your chest x-ray and your 12 lead EKG. But let's put more emphasis and focus on the echocardiogram because that's going to be the gold standard test for all of these, okay? So if we were to take a look at the echo for dilated cardiomyopathy, what would we see? It's very simple. Think about all the stuff that we've talked about to this point, right? What's going on with the ventricular thickness? Very, very thin ventricular walls. What's going on with the diameters of these ventricular cavities? They're gargantuous, big. Ejection fraction, what did I tell you? Because of the thin walls and because of the large ventricular diameter, what happens to the ejection fraction? It goes down, their contractility goes down, so their stroke volume goes down. And so because of that, they have a reduction in their ejection fraction. The other thing, are the ventricles very, very good at being able to distend and take on a lot of blood? Yeah, that's why they're very dilated and very thin walls. So their ventricular compliance is through the roof. They have a good amount of distensibility and a good ability to accommodate large volumes of blood. And last but not least, if we were to throw on a Doppler, so Doppler will give you a look at the blood flow, okay, across the different parts in the chambers and the valves of the heart. Do you think we would see any types of valvular abnormalities or murmurs that would be present? Absolutely. Because of the stretching of the annulus in dilated cardiomyopathy, you could see regurgitation on the Doppler studies, particularly mitral regurgitation and tricuspid regurgitation. So that's a big thing to remember. Let's keep going down. So if we go through the next part, hypertrophic cardiomyopathy, let's keep all of this stuff fresh in your mind so you guys can easily compare these. Think about hypertrophic. What do you think about the wall thickness? Well, the wall thickness is definitely, it's increased in comparison to a normal ventricular wall. But where is the thickness the biggest? The interventricular septum. So we call this an asymmetrical thickening of the ventricular myocardium. So there will be an increase in thickness, but it is asymmetric, primarily the septum. What happens to the diameter of this cavity? We'll just look at it. Is it big or small? It's small. And then what did I tell you about the ejection fraction? If you have more myocardial cells, there's a hypertrophy of them. There's an increase in the size of the myocardial cells. Do you think they're going to have an increase in contractility or a decrease in contractility? They're going to be hypercontractile, so their ejection fraction, we can say, is actually normal to increased. They can have a reduction in stroke volume, right? We did say that if their obstruction is very severe or if they don't have a good amount of preload. But for the most part, because their ventricles are super contractile, their EF is usually pretty preserved. So we call that a heart failure with a preserved ejection fraction, normal EF. Ventricular compliance, what did I say? Because they're really thick, very small diameter, are they good at accepting blood during diastole? No, it's a diastolic dysfunction, my friends. So therefore, ventricular compliance is reduced. Last but not least, is there any valvular abnormalities? We throw on Doppler flow. We look at the blood flow across the valves. Am I going to see any types of obvious regurgitation murmurs? Yes. Remember I told you, during the systolic process, what happens to the anterior leaflet of the mitral valve? Whoa, it gets yanked. Systolic anterior motion will pull it towards the interventricular septum, causing that dynamic obstruction, and blood will just squirt right into the left atrium. And this is a mitral regurgitation via the systolic anterior motion of the mitral valve. Another thing you'll see on the echo is whenever the interventricular septum contracts and bows inwards, you can see the dynamic obstruction. Don't forget that. Restrictive cardiomyopathy. This one's a little interesting. So if you look at the wall thickness, is there any increase or decrease in wall thickness in comparison to normal myocardiums? It really varies. It depends on the patient. There could be some types of wall thickening in some of these patients, but if it is, the key thing to remember so that you don't confuse yourself on the exam is if there is wall thickening, it is symmetric. If it's asymmetric, it is hypertrophic cardiomyopathy. Don't forget that. Diameter of the ventricle cavity. If the thickness does increase, which is variable, if it increases, you'll small and decrease the size of that ventricular cavity. So do you think that could potentially go down? It could if the thickness increases. But if the thickness stays normal, then the diameter of the ventricular cavity will most likely stay normal. The ejection fraction, what happens here? Well, it depends. Usually, if there is infiltration into the interstitial spaces and there's some fibrosis, as long as you have enough normal myocardial tissue to contract, your ejection fraction can somewhat be pretty much preserved and be relatively normal. However, if the fibrosis and the infiltration gets really, really bad and severe, where you start having less myocardium and more fibrotic tissue, the ejection fraction can drop down. But most of the time, to make it easy to remember, it's relatively normal. Here's a big thing. Ventricular compliance. Is it want to distend, accommodate blood during the diastolic process? No, it doesn't want to stretch because it's fibrotic, it's infiltrated. Not very happy with doing that. So its ventricular compliance will drop. That's an identifier of diastolic dysfunction. Diastolic dysfunction, systolic dysfunction. Last but not least, if I look at the valvular abnormalities, put on Doppler, will I see any types of murmurs? Remember, atria have to get big and plumpy because they have to accommodate a lot of volume because blood won't go into the ventricles. So what happens to those atria? They get big. If they get big, they stretch out the annulus of the mitral and tricuspid valve. This can lead to mitral regurgitation murmurs and tricuspid regurgitation murmurs. So pick up the key things from this echo, which will easily help you to differentiate these. The less significant tests, which we're going to kind of blow through here relatively quickly because they're not as high yield, they're not sensitive, they're not specific, they're not going to tell me the diagnosis. It could be your chest x-ray and EKG. For dilated cardiomyopathy, remember they have that left-sided heart failure. If their systolic contractions reduce significantly, blood can back up into the lungs. What can that cause? Pulmonary edema. If the ventricles are super dilated, the atria are dilated, the heart can look really big on chest x-ray, and that can cause cardiomegaly. But oftentimes for patients with hypertrophic cardiomyopathy and with restrictive cardiomyopathy, there's no really specific signs. It's pretty much most of the time normal. You're not going to see anything that pops out. If it is, it's super minor and very nonspecific. EKG, most of the time you're stretching these atria. You're stretching the atria in what? Dilated cardiomyopathy. They're getting thin, they're getting large ventricular chambers and atrial chambers. That's stretching them out. That increases the risk of electrical remodeling and atrial fibrillation. You're also, if your ejection fraction in these patients, dilated cardiomyopathy, drops down really low, they're at high risk of VTAC and VFib. And so sometimes you may even see that on their EKG. But the big thing, atrial fibrillation, that's the most important one for dilated cardiomyopathy. So they have high risk of thromboembolic events. Next one here, hypertrophic cardiomyopathy. Again, if you cause the atria to get hypertrophic and thicken, you can definitely alter some of the electrical remodeling, increasing the risk of atrial fibrillation. But here's the worst case scenario. What happens if they get significant reduction in coronary perfusion to the point where it causes VTAC and VFib and sudden cardiac death? These are the scary ones. Please don't forget these. So atrial fibrillation is the main one here for dilated. VTAC, VFib is the main one here for hypertrophic cardiomyopathy. Another thing that you may see, just to add on in case they throw it in the EKG, is that the ventricles are thick, right? So because of that, if you look at the R waves and V5, V6, they're going to be tall. And then the S waves generally and your V1, V2, V3 will be low. But also you can have these things called pseudo Q waves. Okay, Q waves are usually indicative of like an infarction, but in hypertrophic cardiomyopathy, it's just because of the septal hypertrophy. And so these can show you these deep Q waves in the inferior leads, 2, 3, AVF, and sometimes the high lateral, 1 and AVL, V5, and V6. But don't forget these ones at least. But again, big thing to take away, VTAC, VFib, this one, atrial fibrillation. Last but not least, restrictive cardiomyopathy. Again, you're getting biatrial enlargement. If you stretch the atria out, you increase the risk of electrical remodeling, increasing the risk of atrial fibrillation. Pretty much a common across all of them. But what's the real one I want you to know? You can get AV blocks and conduction blocks. So if I have that deposition or fibrosis that involves the AV node, can I allow for electrical potentials to go into the AV node and down to the ventricles? No. So I can cause an AV block. If I put deposits into the right bundle branch, the left bundle branch, or the Purkinje system, am I going to have electrical potentials going through those bundle branches properly? No, and these can produce bundle branch blocks. Don't forget that on these patients. Plus, you know what else they could have? If you deposit and fibrose a lot of the myocardial tissue, you decrease the electrical activity of their QRS complexes. And sometimes they have low voltages of their QRS. But this is the big thing. Blocks for restrictive, VTAC, VFib, pseudo Q waves for hypertrophic, atrial fibrillation, big one for dilated cardiomyopathy. Now that we've hit those, let's hit home one of the last things, which is a huge differentiation between constrictive pericarditis and restrictive cardiomyopathy. All right, so constrictive pericarditis, we'll have another individual video that which will be on pericardial diseases. But when we talk about that later, this will help you to remember it, okay? It's a very big thing to differentiate between these two disorders because especially in the clinical cases that you may be presented, they sound exactly the same sometimes. So what are some of the key features that'll just make you think, oh, this is constrictive pericarditis that they're trying to get me with? Or, oh, this is restrictive cardiomyopathy that they're trying to get to. What's the biggest things that separate them? Well, constrictive pericarditis, the pericardium is very rigid, it's very thick, and it's not allowing the ventricles to expand. And what happens is when blood comes into these actual ventricles, it can produce this kind of plumping sound that you can hear. And this is called a pericardial knock. Okay, a pericardial knock that you'll hear in constrictive pericarditis due to the very rigid and thick and non-distensible pericardium. In patients with restrictive cardiomyopathy, their ventricles are just not compliant. They don't want to stretch, they don't want to distend, they don't want to allow for blood to come in. The atria get big. If the atria get big, they stretch the annulus. If they stretch the annulus, what happens to blood flow into the atria? It gets regurgitated. This can cause mitral and tricuspid regurgitation. You will not see that in constrictive pericarditis. Next thing, if you look at their EKG, they both have low voltage QRS complexes, right? But here's the big difference. This one has conduction blocks because the deposition can occur in the AV node and the bundle branches. That's a big difference on their EKG. What about their echo? Their echo can sometimes be a little bit difficult to see. If you can see the thickened pericardium, great, but sometimes you just only can see the myocardium and the ventricular cavities. And what you want to look for in the echo is that whenever blood is coming into a very rigid pericardium, it doesn't allow the ventricles to distend. They're kind of held and encased in that pericardium. So if blood comes into them, they don't have much room. And so, unfortunately, because they don't have a lot of room, they got to bow into the opposite or contralateral ventricle. So when blood's coming into them, they can't open up. So guess what they do? They start pushing into the ventricle adjacent to them. And this is called a septal balance or septal bowing. And this can occur during ventricular diastole. When they're getting filled with blood, they can't extend because the pericardium is restricting them from expanding. So what happens? They push into the other ventricle and cause a septal bounce. And restrictive cardiomyopathy, they don't do that. The ventricles have a little bit of give. They can actually extend a little bit in the early phases, but they do not produce any septal bowing or septal bounce. What you will see on the echo is that biatrial enlargement, which will be pretty obvious, and you will not see in constrictive pericarditis. Whew. What about CT MRI? So if I got a CT or MRI, I get a good look at the pericardium on these. And if I look at the pericardium of a constrictive pericarditis, what's it going to look like? Thickened and abnormal. Is there any problem with the pericardium or restrictive cardiomyopathy? No, because it's the myocardium. That should be normal. Last but not least, if you took these patients to the cardiac catheterization lab and you looked at their ventricular pressures and you compared the pressure in the right ventricle and the pressure in the left ventricle. If you looked at a person with constrictive pericarditis, the pericardium surrounds the entire heart. So what happens is your ventricular end diastolic pressures, the pressures in the ventricle at their end of diastole, okay? They are going to be equivalent because the pericardium is surrounding the entire myocardium. So there's no kind of indifference between those two. The left ventricular end diastolic pressure should equal the right ventricular end diastolic pressure. And the easy way to remember that is the pericardium is surrounding both of them with a significant and equal amount of resistance to expansion during diastole. In a patient with restrictive cardiomyopathy, which ventricle has higher amounts of pressure generally? The left ventricle. And so in these patients with restrictive cardiomyopathy, it holds true that their left ventricular end diastolic pressure, which is usually the case, is higher than their right ventricular end diastolic pressure because they don't have a pericardium that's equally distributing the diastolic expansion in that process. In this case, the left ventricle usually has higher end diastolic pressures than the right ventricle, and so this would be the case in restrictive cardiomyopathy. That covers the big differences, my friends. Now let's hit it home with the treatment of the cardiomyopathies. All right, let's finish this off, Ninja Nerds, with talking about the treatments of these cardiomyopathies. So dilated cardiomyopathy, let's think to the primary things that would be most beneficial. It's pretty much heart failure treatment. So here's the thing. In dilated cardiomyopathy, they were getting a lot of distension, too much preload. The preload was excessive because the ventricles were so dilated. They were holding on to so much blood that they were just too stretched out. When they're too stretched out, that really reduces their stroke volume because it doesn't obey the Frank-Stallings law of the heart anymore. So what can we do to prevent this excessive amount of preload? Because whenever the preload's too high and our contractility is so low, blood's going to back up and it's going to back up into the lungs and we're going to get pulmonary edema. How do we prevent that? We drop the preload a little bit. So how do we drop the preload? Well, preload is dependent upon venous return, and venous return is dependent upon volume as well as your venoconstrictive mechanisms. But let's focus on the primary ways of volume. So one of the things I can do is I can get rid of volume. I can cause diuresis. So I can give things like furosemide, loop diuretics, which will help to allow for removal of excess amounts of fluids within the body when they're hypervolemic. Or one of the better things is having them restrict some of their sodium intake and restrict some of their water intake, because that'll also help to reduce the total body volume as well. So those are things to consider just to prevent that worsening pulmonary edema and lower extremity edema. Other things that you can do is compression stockings, because that can squeeze on the lower extremities and push blood up as well. Something to think about. Okay, the other problem in these patients is that they have generally a higher afterload. Whenever your contractility drops, your stroke volume drops, your cardiac output drops, your renin-angiotensin-aldosterone systems becomes hyperactive. What does angiotensin II do to your arterioles? Squeezes them. If you squeeze them, your resistance goes up. So then what happens to your blood pressure? It goes up. So your afterload increases. Our poor little left ventricle is not contracting as it is already. We want to reduce the afterload so that way the stroke volume increases. So how do I reduce my afterload? So I can give drugs that inhibit the angiotensin II system. So I can give ACE inhibitors and ARBs, angiotensin receptor blockers. I can also give direct vasodilators, the ones that act on the blood vessels and open them up. Hydralazine, isosorbide dinitrate as well. Those are things to remember. Okay. The last thing is, we talked about the ventricles. They're not really squeezing. They're very thin-walled. They don't have a lot of contractility. Their contractility's down. What can I do? What kind of drug could I give to make their ventricles squeeze harder and pump more blood out to increase their stroke volume? There's a drug called digoxin, and digoxin may be a beneficial drug in these scenarios. The next thing I want to talk about here is we talked about these patients. We said whenever their ejection fraction gets really low, their ventricles get really stretched out, they have high risk of going into what's called VTAC and VFib for a couple reasons. One, if you drop their cardiac output, you don't get a good coronary perfusion. And if the ventricles are just really thin, you're also stretching them out and altering their electrical circuits. And this really worsens their chances and increases their chances of going into VTAC and VFib. So we say in these patients, when their ejection fraction is less than 35, they're at high risk of malignant arrhythmias, ventricular arrhythmias. So we should consider an AICD in these types of patients. Next thing, remember I told you there's something called cardiac remodeling. Because the contractility drops with these patients, the renin-angiotensin-aldosterone system goes haywire. And that system causes the ventricle and the atria to undergo this remodeling process, which worsens the heart failure. We can actually give drugs that decrease remodeling and improve mortality in these patients. What are those drugs that you can't forget for this process? Beta blockers, ACE inhibitors, ARBs, and aldosterone antagonists, because again, they work against your sympathetic nervous system and against that renin-angiotensin-aldosterone system. So don't forget this one. These are good for reducing cardiac remodeling and improving mortality. Last thing I told you, remember, in these patients, dilated cardiomyopathy, what was one of the EKG findings I said was really significant in differentiating? Atrial fibrillation, because you're stretching those atria out pretty significantly. So because of that, if someone has AFib, they have less effective atrial contractions, higher risk of stasis in the atria, higher risk of clots. And so because of that, they can cause embolic stroke. So we should anticoagulate these patients. Also, if their left ventricle isn't squeezing as well, because they have very low ejection fraction, if they aren't squeezing well, there's a stasis of blood flow in the ventricles. They can get clots or thrombi that form within the ventricles. And if those embolize, they can also cause a stroke. So in these patients with a very low ejection fraction or atrial fibrillation, we should consider anticoagulation with things like warfarin or DOACs like apixaban, rivaroxaban, or dabigatran. Last but not least, if the patient is on an AICD, their ejection fraction is really low, maybe they even went to an LVAD, usually in these patients, the only thing that we can really do to improve their overall outcome is considering a heart transplant. That covers dilated. Now talk about hypertrophic. Hypertrophic. Here's the way I want you to remember the treatment for this one. Think about the things that decrease the intensity of the murmur. That's going to improve their condition because it's going to reduce their murmur. It's also going to reduce the severity of their condition. So remember that. What were the two parameters I said? One is that we wanted to increase preload, and the other one was we wanted to increase afterload. But then we'll add on one more. The other thing is, the harder that ventricle contracts, the worse the obstruction can be, and the higher demand of the ventricle. And so we don't want that as well. So we don't want to really increase their contractility too much. So we want to reduce their contractility. So the big things is we want to increase preload, increase afterload, and reduce contractility. So what can we do for those big things? Most important is avoiding dehydration. So one of the things that you may be presented in the case is you have a young male, less than 35 years of age. He's out there playing football. He hasn't been drinking adequate amounts of water. He's working really, really hard, increasing his contractility, and he's getting dehydrated, and boom, he has a sudden cardiac death, or he goes into VTAC, VFib. One of the biggest things to tell these young children is to stay adequately hydrated, to make sure that we keep a good preload so that we don't drop their stroke volume significantly and cause them to go into these fatal arrhythmias. So that's a big, big thing here. Afterload. We don't want to allow for their afterload to go too low, because if it goes too low, then the actual stroke volume will go what? It'll go up, and with the problem with that is that there's less blood in the ventricles. And so one of the things that you want to do is you want to avoid certain medications in these patients. So what can I avoid? Avoid anything that's going to cause vasodilation of the arterioles. ACE inhibitors, ARBs, hydralazine, isosorbide dinitrate, and any dihydropyridine calcium channel blocker like amlodipine, nifedipine, nicardipine, anything like that, stay away from them, because they really can affect your stroke volume and cause the blood volume in the heart to actually decrease, and we don't want that. So again, avoid dehydration, avoid vasodilators. What can we do to decrease contractility? I don't want those ventricles having to go overboard and working too hard because they're already hypercontractile. That's going to worsen their obstruction. Avoid, at all costs, you stay away from digoxin. It increases their contractility to the point where it can become worsened and worsen their obstruction. If anything, if they're possibly going to be one of the that would benefit from it, you can give a drug like a beta blocker or a calcium channel blocker, because what those do is they reduce your contractility and they reduce the demand of the heart, the amount of work that the heart has to do. So it can reduce your heart rate and reduce your contractility. So these may be beneficial for that scenario. Okay. The two last things that I want to talk about is because these patients have very high risk of VTAC and VFib because of being dehydrated, going on the football field and exerting themselves really, really hard. And when you exert yourself really hard, you can get dehydrated, drop your preload. When you work really hard out in the sun, well, you know what the sun does to your actual blood vessels? It vasodilates them. That's going to drop your afterload. And if you're working out really hard, what are you doing to the contractility of the heart? It's increasing. All of these things worsen coronary perfusion and can cause a very quick, fatal ventricular tachycardia and ventricular fibrillation. So if these patients have ever had any diagnosis of HCM with any episodes of syncope or any concern for a VTAC or VFib, they should have an AICD to prevent them from going into that fatal arrhythmia and dying suddenly. Last but not least, if these patients are great candidates for a way that we can invasively fix this hypertrophic obstructive cardiomyopathy, we can actually cut this septum. We can go in and actually cut it. That's called a surgical myomectomy. Or we can take a catheter threaded in through a little vessel that's going to the septum and squirt high concentrations of alcohol into that area. And alcohol is cardiotoxic. And so it'll destroy some of the tissues in this area as well. And that can act as kind of like an endovascular technique as a myomectomy. These are the big things for the treatment there. Okay, last but not least is the treatment for restrictive cardiomyopathy. What do we do for this one? It is essentially the same as dilated cardiomyopathy. We just are gentler. That's the big thing here. So we want to gently reduce the preload, okay? Gently reduce it because in these patients, sometimes they can get pulmonary edema. We don't want that. So how do we do that? And we also don't want them to have a lot of JVD. We don't want them to have a lot of lower extremity edema. So to prevent that from happening, we can do diuretics and fluid restriction, but very, very gently. Don't do too much of it because you can actually over-diurese them and make them worse. We want to gently reduce the afterload. Sometimes if we do this too much, it can drop their pressure and cause them to become hypotensive. So if their pressure can tolerate it, you want to reduce the afterload a little bit so that the stroke volume can improve. And so we can give things like ACE inhibitors, we can give hydralazine, isosorbide dinitrate, and even dihydropyridine calcium channel blockers like nifedipine, amlodipine, nicardipine. The other thing is anticoagulation in these patients. Now this is interesting, right? Because we said that they have biatrial enlargement that causes atrial fibrillation. But you know what else is another weird thing? In these conditions, they have fibrous inflammation of the endocardium in some of these cases. If there's inflammation of the endocardium that causes endothelial dysfunction and injury, that increases the risk of platelets sticking to it and causing thrombi. So in these patients, not only do they have a high risk of causing embolic strokes, because of AFib, but also they have inflammation of their endocardium. So because of that, they are at high risk for developing embolic strokes, nowhere near as high as dilated cardiomyopathy. Please don't forget that, but they are at risk. So we should consider warfarin or DOACs like apixaban, rivaroxaban, or dabigatran. Again, the most important thing is often in these cases, the fibrosis, the infiltration process is irreversible. It's already been, it's already occurred. We can try to treat the underlying cause, but the damage that has already been done, we can't reverse that. So oftentimes in these patients that we've tried all of these conservative heart therapy measures and it doesn't work, they often result in a heart transplant to remove the fibrotic and infiltrated heart and put in a new, more proper myocardium. But again, you have to fix the underlying issue. All right, last thing I want to do is I want to hit the most important clinical pearls to really stick in your brain for these 3 different types of cardiomyopathies. So what are some clinical pearls to take away as the big overarching theme for these? So just if you had a couple things to remember. Dilated cardiomyopathy, just don't forget that these patients have a very high risk of thromboembolic events because of their low ejection fraction and because of the high risk of atrial fibrillation, because of their systolic dysfunction. And hypertrophic, big thing to take away from these is that these patients, often they're young athletes, less than 35 years of age, that have a complete sudden cardiac death while on like a football field or a baseball field. And again, that is the big thing for this one. And last but not least is restrictive cardiomyopathy. They often have that jugular venous distension that does not change during the inspiratory process. And what is that called? A positive Kussmaul sign. And these are very important, big clinical pearls as differentiating factors between these cardiomyopathies. Engineers, I hope you enjoyed this video and I hope it made sense. All right, as always, until next time.